RS4 Excimer laser system. And you need to, anybody who's doing cases here, you're going to have to take this course, and we're going to do a wet lab. And so the battle plan is I'm going to get the seniors done in a wet lab next Thursday, and then I'm going to get the rest of you all done on another wet lab. And so I have to have the machine here on site, and I've got to have the Johnson & Johnson rep here. And so it takes a lot of coordination, but we're going to do a trial run next week with our 4 seniors, and then we'll take care of the rest of you. Okay, take home point number 1, the importance of human interaction. So here we are, I'm talking about human interaction, and we're doing a Zoom conference, but nevertheless, eventually we'll get back to normal, but the Zoom has actually been very useful. We don't have to be on one side, and I know there are folks on call, and I've been answering lots of pages the past few minutes, and so that's why I'm a little discombobulated, but look forward to the day that we're back in one room. Okay, so the purpose of this presentation is certify physicians to perform the custom view and the iDesign 2.0 and the conventional procedures with the STAR S4. So custom view was our first wavefront system that we had here, but we don't use that anymore. It's going to be all iDesign 2.0, and I'm going to explain what that is. So in addition to completing this course, it's the responsibility of physicians to read and understand the STAR S4 Excimer laser operator's manual. You should have access to that online. The WaveScan operator manual, the iDesign 2.0 manual, and again, I'm going to give you all a copy of this lecture as well that you can refer back to. So please take your time and go through it. You can't remember all of it at once, and so repetition is going to make you a great doctor. So, so steps for certification: you've got to create an account in AMO Advantage. Hopefully you've done that. You're going to attend a live certification course or complete a web-based certification course. That's what we're doing now. After that, you can print a certificate, and then we're going to do a wet lab ahead of time. You know, as a resident or fellow, you can do intra-LASIK with a trained supervisor or teacher. That's either me or Dr. Sutphin. To get femtosecond laser training, you know, to be certified so you can go out and practice, you're gonna need a proctor. That'll be me, and we got to have 5 patients or 10 eyes. I think that's a lot to ask, but that's what they do, and it actually works out okay. So we're not doing what's in red on Thursday, but you are going to be certified to use a laser. I'm hoping that if you've got LASIK cases to do, I'm going to be by your side. I will get you through them because I've done lots of LASIK cases, and I am a trainer for the femtosecond laser. So we're doing the best we can. All right, what's our agenda? We're going to introduce you to the STAR S4 laser, introduce you to iDesign 2.0 treatments. We're going to look at indications, contraindications, warnings, and precautions, pre-operative evaluation. We're going to review, I'm not going to do wave scans. We're going to, or custom view, but we're going to do iDesign only review. We're going to look at surgical recommendations, the steps and the procedures, and look at also conventional ablations. And so when do you use each? Okay. How do I get this thing out of the way here? There we go. Should be down here. All right. Okay. The STAR S4 laser that they're using is a 193 nanometer Excimer laser system. Is capable of delivering conventional treatments, meaning that we have to base our treatment on the refraction that we get in the examination room. It can do wavefront guided treatments, it can do topographically guided treatments, and it can do therapeutic treatments or for things like corneal dystrophies or irregular corneas. And so that lecture I'm going to have to give you later because it's another very detailed lecture. So what happened here? I'm locked up now. There we go. Okay. All right, I said I wasn't going to go through the components of the custom view procedure, but all right, I've got it here. The custom view procedure is the old technology. It's a wavefront guided treatment. There's 3 components to it. You've got a wave scan or a wavefront system to measure the wavefront of the eye. You've got software to reconstruct and calculate ablation profiles, and then you can execute it with the STAR S4 laser. And so you should know this. This is definitely going to be a test question. And so the WaveScan system, you should know about Hartmann-Shack wavefront aberrometry. And so in the custom view system, the early system, it used 264 points. And so whereas our iDesign 2.0 uses 5 times that information, 1,280 points. And so the way things are set up is the WaveScan will shoot shoot light rays through the eye. They bounce off the retina and it creates a wavefront as it exits the eye. It measures that wavefront, and so it knows what a normal wavefront should look like. Any aberration from that, it can make adjustments and therefore put this treatment onto the cornea, and therefore when light rays exit the eye, it's a perfect wavefront and it's going to give the patient perfect vision. And so this is the basis of these wavefront guided treatments. And so, they'll use special physics, the Zernike and Fourier reconstructions, and they use it for treatment. And I'm not going to go into all of that, but okay, I'm going to move on here. All right, on our laser, it uses variable spot scanning with the active track centering and iris registration. And all of that's going to be very important in helping us keep everything aligned in surgery, and so that we have the best outcomes, okay? The laser suite, when you get there, it's going to look something like this. So you're going to have a bench in the center, as shown right here. You'll have the femtosecond laser on the left, and you'll have the Excimer laser on the right. We'll have the iDesign outside the room to get measurements on the patients prior to the treatment. And so SightPath, when we first started using their system, they use an IFS 60 femtosecond laser, an older model, but it's sufficient for learning. They've since upgraded to the IFS 120, which is like awesome. We can make LASIK flaps now in, I don't know, 13 seconds or something like that. To give you an idea of how technology has advanced, when I first started doing these in like 2001, it took 2 minutes to make an Excimer laser flap using femtosecond laser. 13 seconds now, so we're getting much better. Okay, here's iDesign. Why do we use iDesign 2.0? What does it mean? So we use a high definition sensor, gives us 5 times the resolution of the previous system. So you get more wavefront information. It's provided for you so you can do more advanced treatments. It's very easy to use. It's easy for our technicians to obtain the measurements. We can treat a broad number of patients. We can treat patients from maybe +3 to -11. And in that group, I mean, we have almost 99% 20/20 within that range. I mean, it's like really good. And so, again, 2 out of 3 eyes that we treat are going to be 20/15 or better, and even 54% are up to 20/10. So we've got great system. We just got to get patients in to do this. Okay, so I'm going to move forward here. This talks more about the WaveScan. All right, I'm just going to move on here. Realize when we're doing these treatments, we're doing a topographically guided treatment, and we're doing a wavefront guided treatment. And that's why our numbers are so good. We have such a high numbers of patients that are 20/20 now. You don't need to be afraid that, you know, you're operating on an eye that looks normal to you. You could just think about it that I'm helping the patient see better and function better, and not be afraid and just move forward. Okay. Large pupils in laser refractive surgery can create problems. We don't have that issue to worry about now. It's like our treatment zones are out to 8.5 millimeters. I very rarely have a patient complain to me about night vision glare and being disabled by that. It just simply doesn't happen now. And plus, we're going to choose patients who we know are going to be winners too. You're more likely to have photopic issues at night in your hyperope, because you better be dead center in those patients. And so I'll explain that later on. Okay. So when a patient comes in, it's up to us to design a procedure for the patient. And so a patient will come in, and we're going to, we'll have our manifest refraction in the exam lane. We'll have a cycloplegic refraction in the exam lane. And then the eye design is going to produce its own refraction at infinity for your patient. And then we have the ability to adjust that refraction. So we can we can add up to minus 0.75 diopters to plus 2.75 diopters if we want to do a monovision treatment. And so this is one thing that I could not do when we had the custom view platform. So iDesign has everything covered. All right. This is a slide that shows that the iDesign will give you a refraction at infinity, which will add a little bit extra myopic correction. So when you refract somebody in our exam lanes that are short, they're accommodating actually to see there. And so iDesign takes that in consideration. And so it might look like you're overcorrecting patients when you see that, but that's what they're doing, is they're taking in consideration our short exam length, and they're adding that extra corrections. And that's one reason why things are so good. If you have a patient who's approaching presbyopia, you may not want to follow the iDesign program, and you may want to cut back a little bit so you don't overcorrect them. Again, we will talk about that. Most of your patients are probably going to be younger. You won't have to deal with all of this. Okay, what I'm showing here is the length of your examination lane and optical infinity. You have to take that in consideration when you're building your treatment for patients. I've done that already for patients, and so you don't have to worry about that, but you need to know the method to my madness. And so this is what I'm showing you. And I don't expect you to remember all of this. We got a lot of slides to go through, so I can't go through everything in detail. Okay, refractive indications. Who's an indication, who's a candidate for laser vision correction? So we want patients usually who are 21 years of age or older, and they've got a stable refraction. Like my mama said, keep it simple, stupid. And so that's all I'm going to say. And so what's the definition of refractive stability? I mean, it can be too much change in refraction. I mean, myopia less than a half a diopter change, hyperopia less than a +1 change, mixed astigmatism less than +1 change in cylinder, and same thing for high myopia. So should be pretty stable over time. So you want to see multiple refractions that look pretty similar. I've already talked about our range. Again, keep in mind, we can do +3 to like about a -11, and we can have almost 99% patients are going to be 20 or better. And the cylinder can be up to a +5. So conventional laser, we might be able to treat a little bit more. Conventional laser doesn't take away quite as much tissue. I want you to remember this number. So when we do a custom treatment with iDesign, we're taking away about 20 microns of tissue per diopter. With a 6mm treatment zone and conventional treatment in myopia, it's about 12, to give you an idea of the difference. And so we're taking away a lot more tissue to get much better outcomes. But sometimes there might not be enough cornea available, and sometimes you might not be able to get a wave scan reading, and you might need to be able to do a conventional treatment. And so just keep this slide in mind as well. Contraindications to surgery. Of course, we don't want to do surgery in patients that have collagen vascular disease or autoimmune deficiencies. It makes common sense. They don't heal very well. They might be on immune suppression drugs. Women who are pregnant or nursing, the cornea thickens during pregnancy. The tear film is abnormal in pregnancy, and so it makes sense. We want to avoid that group. We're not hating on women, but we got to wait until the hormonal changes get more normal, and then we can have very good outcomes. Patients with signs of keratoconus or abnormal corneal topography, it makes sense, okay? Patients who are taking the following medications, Accutane or amiodarone, those are metabolized by the cornea. You can get very poor wound healing. You can get significant dry eye, and just you want to avoid these medications, okay? Pictures on the right show somebody with pellucid or keratoconus. And so again, be on the lookout, know what that looks like. So this is pellucid. The reason this is pellucid, there's thinning inferior to the apex of the cone. And they've got this kind of crab claw looking appearance. And so this is what pellucid looks like, but be on the lookout for both. LASIK or PRK is not recommended in patients who have herpes simplex or varicella zoster. I think that's self-explanatory. Have allergy or atopic predisposition, and many times if you rub the eye, you get keratoconus. If you have significant dry eye that's unresponsive to treatment, and also uncontrolled diabetes. I don't think I have to elaborate any more on that. I think you all know. Patients who have pacemakers or defibrillators, you need to be careful. Sometimes they will misfire in the presence of an electromagnetic field like the Excimer laser. And so be careful. I've actually done surgery in VA patients who have had these, and I had to talk about that and everything. And so, but again, you don't want to maybe do your first cases in patients with this type of history, okay? Precautions. Patients with corneal neovascularization. This patient on the right, you don't want to sign them up for LASIK, okay? It's just, you're going to get bleeding, you're going to get abnormal healing, it's going to be a pain in the butt. You may not want to do PRK, and so you might want to fix the neovascularization first. They might need steroid, they might need subconjunctival Avastin or something different, or maybe verteporphyrin ablation on the cornea to get rid of neovascularization. And so anyway, you want to try to avoid these patients if you can. Let's see, what else is this saying here? It's saying here that patients who are under the age of 21, where maybe you haven't documented stability of a refraction, be careful. Okay, I've done treatments in patients who have been amblyopic, and maybe they've had anisometropia, and we're trying to do amblyopia therapy. Sometimes you have to think out of the box and do some things to help some patients. And so try not to make that your first patient if you can help it. Okay, it's saying here that the laser systems, correction hasn't been established in progressive myopia, hyperopia, and astigmatism, common sense. Ocular disease, corneal abnormalities, or previous corneal intraocular surgeries. You might have, I have to do a case next Thursday in someone who's had a DALC for acanthamoeba, and they can't wear a contact lens. And so, I've got to tell that patient that, I don't know how he's going to end up, but I know if I leave him the way that he is, he's not going to do any better. I'm going to make him better. And what we're going to do is we're going to do it in two. I'm going to do a non-custom treatment on him and get his refractive error down. And then if he's not happy, he'll be in the range for a custom treatment, and then we'll get him perfect. So I've already been thinking about this. So again, patients with a history of glaucoma, you want to be careful, because if you remove over 100 microns of stroma, you can't reliably check the pressure with applanation, with Goldman applanation tonometry. And so it makes a difference. You want to make sure that you leave greater than 300 microns of residual stromal bed after LASIK, and 400 microns in general after all procedures, so that patients don't have instability. And again, you want to avoid Imitrex because it enhances myofibroblast contraction in the cornea, and you can have abnormal results. Okay, as mentioned before, you need to leave at least a posterior thickness of 300 microns after LASIK. Don't violate this. And there's some practices that are going to 350 microns, and I can recommend that as well. So just remember this: when we do laser vision correction, we want a residual cornea thickness after LASIK and PRK to be 400 microns or more, and we don't want to violate the posterior 300 microns. If you violate those rules, you'll end up in court. I guarantee it. And you don't want that. You don't want to end up in court because, when the patient gets up there testifying and they look all sad, they're going to vote against you. All right. Here's a case. Here's a video. Here's a case that you don't want to sign up for your first case. So this guy was a prisoner. He got into like a bar fight or something. I ended up having to do a transplant, then a cataract surgery. He had irregular astigmatism. And so here's a case where I did intralasic after a penetrating graft. You can see there, he's got irregular pupil. I'm kind of using the force to help me line up. But this case did really good. So this is the left eye. I'm using a temporal hinge. I did this case in 2012, and so I don't have a very good pupil to fixate on, so I had to do all of this myself. And so I basically did a LASIK flap within his PK. I knocked down his myopia and astigmatism considerably. I got him to 20/30 and he was still complaining. I lifted the flap and I did an enhancement procedure. I got him to 20/20. And he still said, "Doc, is this the best that you can do?" And I said, "Yeah, this is the best that I can do." He says, "Well, I appreciate you, man." He says, "You've worked really hard, but this still sucks." And so I didn't take that in a bad way. What I'm doing is that I had to do a mixed astigmatism ablation, so it's out to 9 past my keratoplasty button, so I don't damage the keratoplasty wound or the LASIK flap. I had to cover it, line up as best I could, and then I did my treatment. And so, again, to help people, sometimes you have to do some things creatively, and maybe they're not by the book. Again, don't make this your first case. But we did good here, and I did this case in 2. So here you're seeing part 1. I got him close, and then I lifted the flap again, and I did a customized treatment the second time, and we got it done, and he was actually 20/20 afterwards. All right, let's go back to my slides here. Okay. All right, so safety and effectiveness of wavefront guided LASIK surgery has only been established for these zones here. I'm not going to go through all of that. You don't need to know all of that specifically. All right, so when we have our patients come in, you're going to see me in the morning. I'm going to be very nervous. I'm going to be checking the temperature and humidity in the room. And so it's best to perform with the humidity between, actually it's a range. We use 25 to 45, and the temperature needs to be between 68 and 72, but it's published 40 to 45%. It's hard to get our room, in the wintertime, it's hard to get our rooms down upstairs and above 35%. So I aim between 30 and 45. And so remember this, because you'll be tested on this maybe on one of your board tests. And so make sure that your post-operative keratometry value after surgery is greater than 36 and less than 49. So if you are too flat, you will have bad optics. If you are too steep, you will have bad optics. And I think it makes sense. RK patients who are really flat, they have awful vision. Keratoconus patients, once they start getting around 48 or 49 diopters, they don't see so well. It makes sense that the same would follow after refractive surgery. If you have too low of a temperature or humidity, you will get an overcorrection. And so because the stromal bed is going to be less hydrated. In converse, if you have a higher temperature or higher humidity, you will get undercorrections because you've got increased water in the stroma. Remember that, depending on where you go to practice. In Denver, you're going to practice different than if you were in Miami. Okay, you have to build your nomogram differently. So it's your responsibility to understand and adjust to these factors, okay? Let's see. Yeah, all surgeons should read the professional use and information prior to performing the procedures. That's well explained. So at KU, it's expected that you perform a complete examination and disclose the chance for 20/20 vision, disclose the risk for complications, show a video of the procedure, discuss post-operative recovery time, and if possible, obtain informed consent and place it into O2. That's me talking there. That just kind of helps speed things up. So Okay. If there is a complication following the procedure, then Abbott Medical Optics requires us to report this immediately, and so that they can make their own report to the FDA and they can determine what happened and help us avoid future problems. And so it's very unlikely that's going to happen, but they're telling us to do that to cover their butts. Okay. All right. Every single person on the planet has a story, so don't judge people before you truly know them. And so the truth might surprise you. And so this is from The Alchemist. And so I appreciate you all listening. Let's talk about the patient evaluation now. So patient evaluation, there's 4 things we're going to discuss: the history, the examination, ancillary test, and then discussion of findings and informed consent. So patient history, we're going to look at the expectations, the social history, the medical history, pertinent ocular history, patient age, presbyopia, and monovision. All right, inappropriate patient expectations, trust me, leading cause of patient dissatisfaction. Talk to your patient, look at them in the eye. And if you can't, if let's say if you're not the most social person, you better have somebody in your office who can talk to these patients and build a rapport with them, okay? If you can't do it, don't do laser vision correction, okay? It will be a headache. You'll be in court and you're going to lose. Surgeons should explore expectations related to the refractive results, like, you know, you should tell them their uncorrected visual acuity and help them understand. You know, I mean, hopefully most patients, they're hoping they're going to have uncorrected vision and it's going to improve their self-esteem and all of that. And you want to be honest with them. What are their chances of achieving their goal? And so talk to them and ask them what they want from surgery, and then talk about what are the chances that we're going to achieve that. You need to explain to patients that refractive surgery will make the eye see better than it does, will not make the eye see better than it does with contact lenses and glasses. Okay, so don't go in saying, oh, you can throw those contacts away and you'll never need them again, and you're going to have x-ray vision like Superman and all of that. Don't do that. Tell them that, whatever you see in your contact lenses and your glasses, yeah, I can achieve that with the laser. And I can tell you this, I mean, don't tell patients this, but most patients, they have better vision after laser vision correction than in their contacts and glasses, because now we're correcting their wavefront aberrations and topographic aberrations, and they got better vision. Okay, don't tell them that. Okay, but in truth, we probably are making them better. Tell them also refractive surgery does not prevent future eye problems like cataract, glaucoma, retinal detachment, AMD. They still need to come in from time to time and have good eye exams, and to make sure that myopia is not progressing and retinal tears and all of that stuff. They still need to come in from time to time, depending on what's going on with them. So. All right, social history. You want to identify what are their work requirements. What's their requirements at home and at work, and are they a preacher? Are they military personnel or a firefighter or a policeman? Are they an athlete? Are they increased risk for ocular trauma? If they are an increased for ocular trauma, maybe we want to gravitate to PRK. I've seen so many people late after LASIK, they get punched in the eye, or maybe it's something scratches them, and that LASIK flap creates a problem. And so, if they're like a WWF fighter, you should probably do PRK. Okay. Or if they make their life pulling weeds and they're in contact with rose bushes all the time, maybe PRK is better for that person. Find out if they're a high myope with presbyopia, and then you're going to have to plan what's the monovision plan for them, or they're going to just wear readers. And so you really got to discuss that. When I started out, I did this one guy. He says, "Oh, I want to be 20/20," and he was a -5 myope. He was 52 years old. I made him 20/20. I corrected all of that. I said, "Boy, I did good. I can't see to shave, doc. I can't read my watch." He was like the most unhappy person, and so you got to talk to folks. Medical history. evaluate their systemic conditions, their prior surgeries, their current and past medications, search for the presence of diabetes, connective tissue disease, like we discussed before, immune compromised states, and all of that. Go over their medication list, make sure they're not on the medications that might create issues. And I have them listed there. Refractive surgery is contraindicated in the pregnant. In pregnancy. And then again, as I mentioned before, there's a relative contraindication, those with cardiac pacemakers and implanted defibrillators. Determine if there's dry eye, blepharitis, recurrent erosion. Like if someone has history of AMD and recurrent erosion, you're not going to do LASIK on that person. You're going to do PRK or you'll do nothing. They'll love you if you do PRK because you'll get rid of their refractive error and they'll never have an erosion again. You do LASIK on them, you're going to have problems. You need to look inside the eye and make sure there's no lattice degeneration, retinal tears. Make sure they have stability of refraction. Go over their contact lens history. If they have soft lenses, they need to be out of their lenses maybe, a few days to a week or two before the exam. If they're in gas perm lenses or PMMA lenses, they need to be out of the lenses maybe a month. Sometimes even longer before you can get good measurements because those lenses mold and change the shape of the cornea, and then you might not have the best outcome. All right, we know that. Pictures on the right show somebody with dendritic keratitis, and you want to be on the lookout for that, and also the keratoconus down below. You need to be able to recognize that right away. Okay, patient age, presbyopia, and monovision. Okay. The change in vision with aging process, you have to discuss with your patient. So you need to have a discussion of monovision. And so, when patients hit to be about 50 years of age, they only have about a diopter of accommodation left. Okay, and so they don't have a big range, and it gradually slows down after that. And so it's a big change between 40 and 50. And so, that's kind of like going to be your sweet spot. You better know how to talk to patients and to do things right. So I can tell you that if you leave someone with about a minus 1.5 diopters of myopia, they can cover a lot of territory. They can do computer distance, they can do their smartphone. I think that with that much imbalance, most people can tolerate it. If their dominant eye is set for infinity and their non-dominant eye is set for about a minus 150, I think you're going to have a busy practice. But you might have to test patients and get them used to it. Do a contact lens trial run. And I test them right there in the office. Like when I was at Iowa, contact lens clinic was right next to me. They had all kinds of disposable lenses. I would correct the dominant eye fully. I would leave the non-dominant eye with minus 150 of myopia. And I say, walk around. Could you drive here today with that? Can you do your computer work? And if they told me yes, I'm saying I'm signing you up for monovision. If you hate it, you just tell me later and I'll just put that extra correction in. And we can say we've tried it. And so it worked out fine. I didn't have to do very many touch-ups and I had a lot of happy patients. And so on examination, you're going to look at uncorrected visual acuity, your manifest vision, cycloplegic. Document all three on the chart. Because when that patient comes in and they say, oh, I'm worse off, and then you can show them their uncorrected vision was 20 over nothing, and now they're at least like 20, 30 or something. He says, you couldn't see anything before. Oh, I guess you're right, doctor. So document that uncorrected vision on the chart. Do your pupil examination. If they have really big pupils, you need to have a consultation with them that, you might have glare after surgery, but I've just told you that our ablation zones are really large today. Very rarely is glare a problem. Look at ocular motility, check your visual fields, check your ocular anatomy, intraocular pressure, slit lamp exam, all of that stuff you got to go through, make sure there are no abnormalities, address them if they're there. Yeah, uncorrected vision at distance and near you need to do. Best corrected vision in current spectacles and contact lenses needs to be documented. Refract to the point of the sharpest vision with the least amount of minus or pushing plus. Get your cycloplegic refraction, refine the sphere, not the cylinder. If they have a large correction, make sure you check the vertex distance, and that's what this is doing right here. and look for latent hyperopia. So you need your you might have to do a post-cycloplegic refraction in your hyperopes. Your hyperopes are going to be your problem children, the younger, especially the young ones, because they have real strong accommodation, and you might need to see them post-op because they may not tolerate a full cycloplegic correction. So back in the day, we used to do the covert pupillometry, and in Iowa we did infrared pupillometry to check pupil sizes and document all of that. Our wave scan machine does all of that now. And so again, pupil size greater than effective optical zone increases the risk of glare. We know that, but very rarely does that happen. And if someone has too dilated of pupils, we maybe want to avoid treatment at all altogether. Here's some early cases that I did. So here's a on the left, you see of someone who has corneal topography, and you can see the black line right here is where their pupil is. This was back in the day when I didn't have pupillary or pupil-guided lasers. I kind of had to line up where I thought it was good and hope the patient was looking on target. This person was 8.25 myope. They worked as a lifeguard out in the sun. Do you think that they had any problems? No, because their pupil was always small. They worked outside and they were like the happiest person ever. I'm betting that if they were probably a truck driver and they drove a lot at night and the pupil dilated, they might have some glare, but I got no complaints from that person. Person on the left was an engineer. He wanted the latest technology and he got a +4 diopter ablation. It was dead center, but he couldn't drive at night. And you can see by this pupil, if it gets out to 8 millimeters, he's got multiple optical zones. And so you really got to have a discussion with patients. Our hyperopic treatments today have a blend out to 9 millimeters. So something like this is less likely to happen. So just realize this can happen. All right. Ocular motility, confrontation fields, and ocular anatomy. Patients with asymptomatic tropias and phorias may develop after refractive surgery. So just got to realize when you change things, it can uncover some latent tropias or phorias, and just be on the lookout for it, okay? You have to build a rapport with patient and talk them through it. They might need prism therapy or something like that, but it's rare. Confrontation field should be normal, and if not, you need to ascertain the reason why not. Orbital anatomy is important. When you do your first LASIK case, you want somebody who almost looks like they've got like Graves' disease. You don't want to have any problem putting that vacuum ring onto the limbus of the eye. So the top picture, man, that's your first LASIK case right there. You'll have no trouble putting the vacuum ring across the limbus, getting suction, and then making the LASIK flap. If you have the patient on the bottom, they're going to be squeezing, they'll squeeze off the vacuum ring and you'll have trouble. So deep set eyes, no, they're PRK all the way. I don't care how many cases I've done, I still live by this today. If I see somebody when their eyes are too deep set, I say, Mama told me to keep it simple. I'm gonna do PRK. Make sure you check the intraocular pressure. Patients with glaucoma should be advised that there may be a dramatic increase in pressure with refractive surgery. So when you put the vacuum ring on the eye for microkeratome or even intralasic, it increases the pressure and facility of outflow. Long-term corticosteroid use can also increase intraocular pressure. Removal of corneal tissue causes a falsely low Goldman appellation tonometry measurement, usually 3 to 5 millimeters for every 70 to 100 microns of tissue removed. Remember that. So hypotony secondary to a ceton or trabeculectomy may be a relative contraindication for LASIK, maybe for PRK too, but definitely for LASIK, because you might not be able to build up enough pressure to hold the vacuum ring on the eye and get your flap done. Okay. Mama said, keep it simple, stupid. Okay, slit lamp exam, you need to be on the lookout for meibomitis and anterior collarettes on the lashes, okay? You got to get rid of all lid margin disease, treat the precorneal tear film in any dry eye ahead of time. Put your punctal plugs in, make the surface great. Blepharitis and dry eye are relative contraindications, but you can treat that and make things better. Look for anterior basement membrane dystrophy, Fuchs dystrophy, keratoconus. You might want to avoid those cases. Make sure you look for lens cataracts and all of that stuff, because if they have cataract, lens surgery is much more effective than laser vision correction in most cases. Dilated fundus examination, you're going to look for signs of glaucoma, optic disc drusen. Patients with disc drusen, I mean, you put a vacuum ring on the eye and make the pressure elevated. I mean, you might have a little semi-anterior ischemic optic neuropathy. And so I tend to choose PRK if I see lots of optic nerve head drusen. That's me. I'm very conservative. Patients with macular disease may notice a greater loss of contrast sensitivity after refractive surgery. So realize that as well. So somebody who's got macular degeneration, you might want to steer them away from laser vision correction because of contrast sensitivity loss. Okay. It's a relative contraindication. Peripheral retina, make sure you look for retinal tears. I've got many patients a few months after I've done laser vision correction, they come up with retinal tears and breaks and they have to be treated. And so, it's life. Okay, ancillary tests, corneal topography, pachymetry, wavefront analysis. You need to calculate the residual stromal bed thickness after LASIK, and you need to do anterior segment OCT, especially if you're doing refractive implant surgery. I'll put another one on there that I didn't put on is, sometimes you might need to do IOL masters in case if the patient is over 50 and they've got what Dr. Dury calls dysfunctional lens syndrome. You might need to steer them more towards a clear lensectomy instead of laser vision correction. So, okay, corneal topography, there are many different methods. I like placido disc topography because it images the anterior curvature very well, and it tells me about irregularities on the surface well. At Chicago, I use scanning slit, which we don't use anymore. It's the first technology to evaluate the posterior corneal curvature. It's out of mode now because it's just outdated technology. Instead, there's rotating Scheimpflug photography, the Pentacam or the Galilei, which is what we have. It gives actual posterior curvature data. You can use high frequency ultrasound. We have that. And you can measure interfaces, you can measure corneal thicknesses very well. The highest resolution topography is coupling OCT with the atlas, the Zeiss atlas to placido disc topography, and so it gives you the highest resolution. We don't have that here. I was at Iowa. I had two of them. I had one at the River Landing. I had one at the Maine University, and so I knew everything about everybody's cornea, and I could predict who was going to get in trouble. But we can do it here with our technology. So we have placido disc and we have Scheimpflug, and so we're in good shape. Okay, corneal topography. What you're looking for? Flat corneas. Corneas less 41 diopters or less, they have an increased risk of free caps, which you see on the right there. That's not the end of the world, but believe me, on doing your first case, you don't want to see a free cap. You want to have your LASIK held on by a hinge, because you'll have probably a heart attack and fall out of the chair if that happens. And I'll probably have one too, but I can help you get things back together. I've been there before. Steep corneas. Greater than 48 diopters, you have the risk of having a buttonhole flap. It looks like a donut when it comes off. And so you don't want that either. And so you want to avoid corneas that are too flat and too steep for LASIK. Okay, you want to do PRK. Again, postoperative corneas flatter than 36 actually, and steeper than 50, you increase the risk of awful vision. So I say 30, 36, and 49. You don't want a cornea approaching 49, and you want to avoid corneas 36 and less. Okay. Realize that the final postoperative keratometry measurement may be estimated by adding 80% for myopia and 100% to the refractive correction of okay, I didn't state that one right. Let's say you have a patient who has a cornea central corneal measurement of 45, and you're doing a 5 diopter hyperopic treatment. Well, their postoperative central keratometry is going to be 50. So you got 100. You're going to add 80% of your treatment to the keratometry. Whereas you'll only, like if they're myopic and you're in 45, you'll have 80%. So they'll end up being 41. I can talk about that later. So anyway. So just realize, and so you have to do that calculation in your head, and that way you know whether the postoperative keratometry is going to be too little or too late after surgery. We'll go over that more as we see patients. I had access to NIDEC OPD, which uses skiascopy with Placido disc technology. It gave you a very good posterior kind of a posterior lenticular astigmatism measurement, which was very accurate. We don't have that necessarily here, although our Galilei tries to give us a reading something like that. It's not so important. We can move on to that. Okay, so here's what we had at Eye River Landing. I would get a readout from the Zeiss. It gives me the Pathfinder 2, which tells me about the patient. It tells me it compares their cornea to many different normals and abnormals. Here, this patient has a 43% chance of having a keratoconus pattern, or maybe a hyperopic laser vision correction pattern. Placido disc images is looking kind of ovoid. I know there's some with the rule astigmatism there. Here, the apex of the cornea is slightly displaced inferiorly, so I'm going to be thinking that maybe there's keratoconus. And here, there's an asymmetric bow tie astigmatism. Bells should go off in your head that maybe this person has early keratoconus, which they did have. So you don't want to do this patient. Instead, you need to be thinking collagen cross-linking. Pentacam might look something like this. Pentacam gives you great information. It tells you all about this is a sagittal map of the cornea, which tells us there's like a central cone. The apex of the cornea is displaced inferiorly compared to the pupil. Here's the posterior cornea, and it gives me corneal thickness data. Again, this is somebody you don't want to be doing laser vision correction on. Instead, you're going to be thinking collagen cross-linking, and they may be too thin for collagen cross-linking here. Or you might need to do epithelium on collagen cross-linking in this case if you want to try to stabilize them. Okay, pachymetry, for many years, I tell everybody that ultrasound is the gold standard. It is the gold standard, but I'm very comfortable with our Scheimpflug technology. It's very close to ultrasonic pachymetry. I don't do standard ultrasonic pachymetry on every examination that I see patients. I'll use the Scheimpflug or our Galilei, and it does very well. And so they're different. I put this slide in to show you the different ways to measure. So you got scanning slit topography, you've got UBM that can measure corneal thickness, you got multiple topography units, the Galilei, Pentacam, and a confocal microscope with a Z-ring adapter. You can measure corneal thickness very accurately as well. And so I did all of those things when I had access to the tools. What's the importance of pachymetry? Preoperatively, thin corneas may reveal keratoconus, and thick corneas may suggest endothelial dysfunction, common sense. If LASIK is performed and results in a thin residual stromal bed, then enhancement surgery may not be possible. And so in this case, here's some images. UBM, you can actually see LASIK flaps very well, and you can do measurements. Here's OCT, Vasanti OCT, where we can measure LASIK flaps, not as high resolution. And here's spectral domain OCT that we had also at Iowa, and you can see the flaps really well. We have spectral domain OCT, and we can see these very well. You can calculate the flap thickness here, and this is the residual bed. And so you need to have if you're going to do enhancement surgery, you need to know all of this information, and you'll have to go to the machine and calculate all of that. So I can tell you this, our iDesign 2.0 is so good, I very rarely have to do an enhancement. Usually if I do an enhancement, the patient has had like a monovision treatment. They look me in the eye and they say, "Doc, I really love you, but monovision really sucks. Can you just go ahead and just put the extra correction in, please?" That's the most common reason why I'll do a touch-up. So wavefront analysis, try to do this, we'll try to do this ahead of time so we can build a treatment before the surgery, but a lot of times we end up doing it on the day of surgery. And so remember, the negative for wavefront guided treatment, it removes more tissue. Sometimes you need that tissue for correction. This is old here. This is what it looks like when you get your readout. And so I put this in because you get a wavefront refraction, you get an idea of what's the chances of 20/20 vision, and then you get a higher order wavefront reading. And so this person here has a high level of coma. Coma is a natural higher order aberration, but if it gets to be too high, what patients have coma usually? The patient that has keratoconus. And so I would look at this map and I would go back and look at the patient and say, do they have anything that looks like keratoconus? Flesher ring, spotstria, anything, any family history. And if they told me, if I found something positive, I wasn't going to cut a LASIK flap. And so that's how I use this preoperatively to help me. All right. I think we've done more here. All right. Yeah, I'm just reiterating here. Status post LASIK, make sure your posterior bed that remains, it's untouched, is greater than 300 microns. This is a patient who had surgery back in the old days, and their residual bed thickness is 261. I would say today you need to make it 300, maybe 320 to really keep yourself safe and out of the courtroom. Anterior segment OCT can be very helpful. Let's say you have a high myopic patient like this patient. This is a patient that's keratoconus. They're like a -20, and they're like, what can you do for me, doc? You can do your refractive implant surgery. And so you make sure they have enough distance between the implant and the cornea, and you can knock off 20 diopters of myopia and be a hero. Here's a case. Take a look at this. Here's a lady who came to me. She had central cones, and she was a good contact lens wearer, but she just wanted to get out of it. She said that if she had she said she was in a hotel room and the fire alarm went off right after she went off, right after she took her contacts out. She couldn't find a way out of the hotel. She said it was too dark, and she said it made her so afraid she came to see me right away. And so what I did with her is look at this. Look at her refraction pre-op, -20 plus floor. I put in this Verisize refractive implant, and look at her refraction. She's a +1.25. I don't know how I knocked off some cylinder, but I did. And so she's effectively like a +150, 20/30 without any glasses on. And so it just made the difference for her. That, you know, without the contact lenses, she could definitely function and do things. And so this is the role for refractive implant surgery in keratoconus or high myopia. And so, okay, so after you do your exam, discuss your findings, whether positive or negative. If the patient is a candidate, the benefit and treatment alternatives should be discussed. The patient should be allowed the chance to ask questions. Important issues discussed are expected uncorrected visual acuity results. I tell everybody, what's their chance of 20/20, 20/15, 20/10? What are the risks of complications such as decreased vision, dry eye? I tell everybody, dry eye. You're going to get dry eye 100% of the time. And so if they start out really dry, you might not want to do their surgery, or you need to do some medical management ahead of time. What's their chance of a flap revision, infection, need for enhancement? I tell them 5 to 7%, and I tell them the most common reason is they don't like monovision. And what's the chance that they might lose their eye? And so what are the pros and cons of unilateral versus bilateral surgery? And you need to talk about all of that. Okay, what are the treatment alternatives? Should be 2022. I need to change my slide. So for LASIK, we can do LASIK and PRK, we can do +3 to -11 pretty comfortably, I think. Surface ablation plus collagen cross-linking is not FDA approved, but it's being done in other countries. We still do Intacs plus cross-linking, and you can do Intacs up to -3. I'm not going to talk so much about that because this is laser vision correction. Phakic IOLs, you can do -5 to -20. And then we can do refractive lens exchanges. but that's mainly going to be the patient who's a hyperope, because if you take out the crystalline lens in a high diopter myope and they're young, you've got about a 10% chance of a retinal tear or detachment at 10 years. A little bit too high. Okay, so again, avoid high excellent myopes who are less than 50 years of age. Okay. All right. Well, listening is the ultimate mark of respect. Listening is the heart and soul of engagement. Listening is the heart and soul of kindness. Listening is the heart and soul of thoughtfulness. Listening is the basis for true collaboration. Listening is the basis for true partnership. Listening is a team sport. Listening is developing. Listening is a developable individual skill. Listening is the basis for community. Listening is the bedrock of joint ventures that grow. Listening is the bedrock for joint ventures that work. And listening is the core to effective cross-functional communication. So definitely appreciate you all listening. Is everybody still awake out there? All right. Everybody's still awake? All right. I've been going on about an hour. Okay. Can I do something? I can only go about an hour and then my bladder tells me I need to empty it. So you all take a little bit of it. Let's take like it's 7:02 now. Take a 5-minute break. Let me empty my bladder and we'll come back and we'll knock out the second half of this. Okay. Oh boy, I got to pick it up. Oh gosh, if you all are still there, I got a lot to go through here. I'll have to get rolling.
We're still with you.
And boy, I dialed this lecture down too, man. Okay. Some of this stuff I can motor through, but they do want me to go through it. It hurts us that we don't have the laser on site where you can go look at it and play. What I'm going to do is I'm going to get a USB drive with all of these lectures so that you can review them. And I think that's going to be good to have it before you do cases. All right. Let's see, where are we at? 7:07, 7:06, one more minute. Is everybody there, or?
Yep, I think so.
We're back.
All right, so I'm going to go ahead and move on then. Okay, so it says here that we need to do our when we do our wave scan readings on patients, it needs to be performed within 30 days of the surgery. So, at KU, we strive to obtain all the preoperative data prior to surgery to improve efficiency on the day of surgery. Sometimes it's not possible. I mean, I only have the laser access like every other month. And so it's hard to do that, but whenever we can, let's strive to do that. And so, what did I say here? At Iowa, we obtained wave scan data on most patients in the morning of surgery, which was time inefficient. However, the final results were equivalent to that published by the United States Navy with both custom view and eye design. So it's not imperative. If we have to do things on the morning of surgery, it hurts our efficiency a little bit, but the results will be good. That's what I'm trying to say. Okay, we've already talked about taking contact lenses out and how they mold the cornea, so I'm going to move forward with some of this. Here's what contact lenses can do. Contact lenses cause reversible corneal topographic changes. Like they might look like pellucid, or they might have this little smiley face on an axial curvature map. And sometimes the elevation map, it might displace the apex, and then they take them out and everything comes back to normal. But you know something? If I see that, I ain't doing LASIK, because if a contact lens can mold and change the shape of a cornea, hell, if I cut a LASIK flap, something bad might happen. PRK, you're much less likely to have issues. Okay, just remember that. Okay, we usually don't do the eye design wave scan visit on the first visit at KU, but I'm striving to get that done here. I put this in. If your wave scan measurement doesn't match your manifest or cycloplegic refraction, I recommend that you do a conventional treatment using the manifest refraction. Okay, so if we do all of this stuff and it doesn't match up, I listen to my mom and she says, keep it simple, stupid. I don't even deal with all that technology, because most times patients are going to do good with conventional technology, and you just have to talk to them. There's something weird about you. I love you and everything, but there's something weird about your eyes. We can't get good measurements. We got to keep it simple and dumb it down, and we're still going to do good. And you have to reassure them, and not everything is possible. It says here, wave scan exams with 6 millimeter wavefront diameter are preferred treatments. Yeah, you're not going to get a measurement unless that happens. So I don't need to go over that. The company wants us to do this. They want us to obtain the wave scan measurement refraction prior to preoperative evaluation, put that in the 4-opter, and then do our treatments. And so in a perfect world, yes, we can do that, but sometimes we can't do it. And so, yes, I agree with that. If you have your own practice and you've got everything on site, do it. And I do think that it will enhance your outcomes, but you can still have good outcomes without doing that. Okay. Make sure you have a good refraction. It's either yourself or your head technician. That's going to be what's most important. All right. I think we've talked about all of this. This is their thing, what they want to know. I'm going to skip through some of this. Okay, cycloplegic refraction. Remember that if you put cyclopentolate 1% in, most people are going to be out of action for a day or two, especially if they have dark colored irides. And so I'll use tropicamide 0.5 to 1% because it gives faster recovery. I find that if I have difficulty refracting them and getting good information, or if I'm suspecting latent hyperopia, I talk to the patient and then I'll get their permission before I put cyclopentolate 1% in, just so that they know what's going on. Just remember, that way you avoid conflict with your patients, loss of work and all of that stuff. So, they recommend that the difference between your wave scan system measurement and what you get in the exam room should be less than a half a diopter in both the sphere and cylinder. All I can tell you, keep it simple. As long as it's close and it's nothing astronomical, you're going to be okay. All right. I'm just going to keep moving on here. All of this stuff is old. I'm going to move forward. I've talked about all of this. Okay, so when patients come in, let's talk about what's going to happen. So they're going to get a wave scan measurement. I designed wave scan reading, a topographic reading, a wave scan reading, and a refraction. Then we're going to design a specific excimer laser treatment for that patient. And then we're going to plug it into the computer, and then it's going to give us what it thinks we should do to make that person good. Okay, this is what has to happen, you know, on the morning of surgery. One thing I didn't tell you, let's say you have a patient that's really antsy, they're type A, they don't believe you and everything. You can build an eye design treatment and have them create an eye design, a lens. Like this is supposed to be like a refractive lens. And the patient can hold that up in front of their eye prior to surgery, and they can get an idea of whether the surgery is going to make them better or not. I mean, that's pretty cool that you can do that. I very rarely have had to do that. I can think of maybe a handful of times in the 20 years I've been using this system that I've had to do that, but it is possible for your specific type A patients who are nervous. So, okay. When a plane crashes, they ask what happened. When medicine, they ask whose fault is it? And so that's why we go through all of this. And so you got to go through all of these pre-flight checks to avoid problems. Okay, let's go over the laser system now. Okay. The hardware overview. So when you see the unit next Thursday, there's going to be this red button that they put that there. If for some reason we need to shut the laser down for something, it's having a malfunction or whatever, we can turn it off automatically. I've never had to do that in all of my life. I don't know when I would do that, but maybe it's on fire or something and I need to turn it off. I pray to God that that never happens. But anyway, we've stated this earlier. The lasers contains a mixture of argon and fluorine gases. The laser operates at voltage ranges from 25,000 to 32,000 volts. You never want to operate the laser in the presence of flammable anesthetics or volatile substance such as alcohol. All right. As ozone builds up, it decreases the amount of energy that passes through the optical pathway. Ozone compensation increases energy stability. To assess the required ozone compensation, a laser system will fire 10 internal pulses prior to treatment. So before you do your treatment, Seth, our laser operator, he's going to be doing all kinds of little firing. He's going to be testing like the smoothness of ablation and testing for all of these various things. You don't have to worry about it, but you just kind of have to have an idea of what he's doing. You know, he's not over there you know, just kind of twiddling his thumbs. He's doing things to make sure things are safe for us. This is just letting you know. Our laser is a variable spot scanning laser. Back in the early days, the laser just had one size. It would create these big craters in the cornea, and you'd have all kinds of wavefront aberrations. It's a scanning treatment. It's very smooth. It's what makes these large diameter ablations work really well, and we don't have glare at night. And so, and a conventional treatment has the same thing too. So You're not giving patients old technology if you're doing a conventional treatment. The repetition rate of the laser varies from 6 to 20 hertz. So you might hear the laser speed up, slow down, depending on what it's doing. And so this is a variable spot scanning. And so that's what's going on. You can vary the repetition rate of the laser. The reason you would want to do that is only time you would want to do that is if you're doing like a phototherapeutic laser and you need every shot to kind of hit at a certain point in the cornea. I might turn the repetition rate down really slow when I'm doing a phototherapeutic laser to treat a lattice dystrophy of the cornea or ABMD, because I want to slow it down so that I can put the treatments in certain places. But you want the laser to be really fast in these LASIK cases because they're very, very nervous. You want to get in and get out before they wake up and understand what's happened. So you don't have to worry about that. But just know that you can vary the laser time. All right. That's all of this is self-explanatory. A lot of these pictures I'm showing you now, these are some of the screens that you're going to see on the laser. And so soon as we come in the laser suite, Seth is going to be asking me, doctor, where's your flap hinge going to be? Superior, nasal, temporal? How deep is it going to be? Are we doing a standard femtosecond laser treatment and all of that? We're going to be answering all of that, and he's going to be putting this information, not us. Okay, not you. The laser technician does all of this. I'm showing this to you so that you have an idea of what they're doing. We're going to, what we're going to do is that we're going to get a readout from the technician on the morning of surgery, and it will have the wavefront guided treatment that we're doing. It'll have a picture of the ablation zone, and then it's going to have a refraction at infinity that the computer creates. It'll have our refraction in the exam room manifest. It'll have our cycloplegic refraction in the exam room. And we've got to choose a treatment based on those three, and then we can do a physician adjustment. Okay, it's not complicated. We'll go through it. Okay, patient alignment. So what this is showing you is this is one of the key cards on the laser. I wish I had a picture of that right now, but this is what the laser looks like. This is the toggle where you turn it and it raises the bed. So it doesn't focus the laser down, but it raises the microscope bed up and down so that you can get the patient in focus. And then you have your illumination, you have your ring illumination, and you have your oblique illumination. And we'll talk about what to do with that. And then you've got your judicial line so that you can make sure that the patient's perfectly aligned within the laser. It's got your active track, and then you've got your wave scan here. And then you've got your ring illumination here that shows you where the laser's firing, and you can increase the intensity of that beam. So know this, you know what the keypad looks like on the laser. When we're doing treatments, all treatments are performed at magnification 1.6. It just gives you a good range of focus, and you're less likely to mess up. Okay, but here are the magnifications on the laser. So here's what the laser looks like. Here's your eyepieces. Here's the toggle where you're going to adjust the level of the bed. And then this right here is the knob where you can do the magnification. And so usually Seth will change that, or I will change that when you're working. I'll make sure that you're at 1.6 magnification for treatments. Maybe when you want to put a punctal plug in, or maybe you want to do some other manipulation or something, you might want to be at a lower magnification or something like that, and we can change that. So good. Oh, this is a great picture here. This is what it looks like. This is going to be your friend right here. And so this is what you're going to be operating with in surgery. So your judicial line, as it tells you, is your patient centered under the laser. This is your iris registration button and the active track. So as soon as you're going to get the patient under the laser, first thing you're going to do is hit your ring illumination, get them centered. you will hit the active track button, and then the very last thing you're gonna do is you'll hit the iris registration to get everything lined up. And then the technician, Seth, is gonna say, we've required iris registration, then we're gonna be ready to treat. This is what it looks like in surgery. So hopefully next Thursday you'll get a chance to use this, practice it. You're going to be able to do some LASIK eyes, hopefully LASIK eyes, PRK eyes, practice lifting some flaps. And so this is what we're going to try to do. All right. You don't need to know this, but there are 3 different vision key cards. They're conventional cards to do conventional ablations, and then there's treatments to do eye design treatments. There are cards to do eye design retreatments, and then there's phototherapeutic cards to do. And so that's a separate course, and I'm going to have to give another lecture for that. And there's another card to build a preview lens for your anxious patient who wants to see what their vision is going to be like. So Seth has to put a card into the laser to get it activated. And so there are 5 different cards. And so these are the different cards. Okay. Seth will go ahead and get the patient aligned. You basically want to get the patient's eye aligned with, there's going to be like an arrow on our system, and you want to get the patient's eye aligned with that when they lie down. And he's going to do all of that. There's a vacuum pillow to help them keep their head steady. This is what the patient is going to see. You've got your side illumination, your oblique illumination. You've got your ring illuminator, which acts like a placido disc as well. And then you've got your vacuum control system right here as well. So please don't touch any of these things. I remember one resident, they did some kind of adjustment to things and they messed things up on one of my surgery days at Iowa. So don't touch any of these things because we don't want SightPath to get on our case. Okay. All right, you want to adjust the operative illumination to keep the operative pupil diameter as close as possible to the wave scan pupil diameter between 5 and 7 millimeters. And so we want to use the lowest amount of light possible to get the job done. You want to be able to see what you're doing, but we want the pupil to be dilated between 5 and 7 millimeters so that we have no trouble getting iris registration. Okay. All right. Plus it keeps the patient comfortable as well. And so over here, you're going to adjust your illumination. I usually turn the ring illumination totally off. I use the oblique and I just use just enough to get the job done. Okay, this is the reticle that you will see. This is like a 3 millimeter zone, 6 millimeter zone, and the outer one is a 9 millimeter zone. And so, okay, inner ring is 4. So 4, 6, and 9. And that gives you an idea of your ablation zones. You have to have the reticle on to proceed with ablation. You can adjust the brightness. Okay. Now the aspirator, this thing right here, can be moved out of position to allow creation or reposition of a LASIK flap and removal of the corneal epithelium. The aspirator has to be in proper position to proceed with the ablation, however. Why is it there? This aspirator is designed to prevent any of the products of ablation from contaminating the surgical suite. So, you know, we live in this day of AIDS and COVID and all of that. And so, you know, when COVID hit, I made sure that everybody still got their COVID tests because I didn't, you know, you can get COVID through corneal spread. And so I didn't want to be inhaling those fumes or maybe having those fumes from the Excimer laser touch my eye and I'm getting COVID. So I'm not doing that right now because we're not in the middle of a pandemic, although the cases are increasing. So when you get in practice, you're going to have to decide what you want to do depending on what's going on in life. But this is what I did as of May 2020. I tested everybody before laser ablation because I wanted to be sure. I didn't want to contaminate everybody with COVID, but we're not doing it now. Okay, the laser has a foot switch to activate it, and there's 2 positions. The first one activates that aspirator, and the second one activates the laser. So make sure you go all the way down. A lot of times, beginning surgeons will press the first position, and they're wondering, hey, the laser's broken, and only the aspirator comes on. There's 2 positions. You've got to go down fully on the pedal. Okay. Remember that. It says here that the active track system, that's your pupil tractor, should be used during conventional and custom view or eye design procedures. So that's self-explanatory. We want to be well centered on our treatments, and so you're going to activate it. This shows you this is the camera system and the infrared lighting. It works together and it monitors the system. It works very well. That's all I'm going to say. The eye tracking system. I haven't had any decentered ablations in almost 20 years, and so it works really good. I've never had to do so. It says that we can choose to do active track manual or auto. I'm going to say this. There's some patients that we might not be able to do active track. Like we had one the other day, a young lady that had nystagmus. All the refractive centers turned her away and said, "Oh, we can't do you." And so the active track couldn't follow her. Her amplitude of nystagmus was too great. I just took a fine Thornton fixation ring, held the eye and what I thought was the visual axis, and then we did the case, and she's 20/25 uncorrected, and she's very happy. So it can be done. So almost 99% of your patients, the active track is going to work fine. You'll have some special outliers, and you might have to hold the eye in position, and you might have to use the force to line things up, but you can have good outcomes. In the early days, I didn't have an active track. I had to line up based on what I thought was the visual axis. Patients did very well. You probably don't want to do patients. You probably don't want to do that patient as your first patient. You probably don't want them to have a very high refractive error. Okay, keep that in mind. So I make my living doing the people who don't fit in very well. They're different somehow. Okay. Again, this is just reiterating what it looks like. This is your board that you're working with, and this is what it looks like on the the reticle reflecting off the cornea. This is what you see in your left eyepiece. Okay, so once the pupil is located, the outside reticle will stop flashing, and that's your signal that you're ready to go. Once the treatment center is set, the center cross of the reticle will flash very slowly. And so the active track system will maintain its position throughout the treatment. You don't have to do much of anything. They tell me that you don't have to touch the eye. Once the active track is locked on, you can just kind of sit back and put your foot on the pedal and do your treatment. I usually follow the patient with the toggle just to, you don't have to do that, but that's the way I've done it for years. Fully depress the laser foot switch to begin the treatment. The center of the reticle will flash slowly during the treatment when the active track system is on and tracking. When the active track system is activated, you may use your joystick to correct for head position motion during treatment. You don't have to, but do not use the joystick to correct for eye rotation when the eye tractor is activated. I think that's a little bit too much movement. So, okay. All right. The treatment will stop or pause when the active track system detects the following conditions. So if the patient's eye moves more than 1.5 millimeters from the treatment center, it's going to turn off automatically. It'll turn off if the vertical position, the z-axis of the corneal surface, moves more than 2 millimeters from its initial treatment position. So if the patient has a head movement up or down too much, the laser is going to turn off, and you got to get them realigned. If the pupil diameter is not circular to within 32% or becomes smaller than 1.5% or larger than 6 millimeters during treatment, it'll turn off. And so if you've got funny pupils, you might have to use the force and do your own treatments. If the eye motion exceeds 0.2 millimeters between video frames, like on nystagmus, it's not going to work well. If there's shadows or dark objects within the field, it's not going to work well too. So we got a limit. That's why you don't want too much light. And if your hands get in the way, it's going to turn off as well. So remember that. There's lots of safety things built in. Okay. I'm going to go through here. Some of these things are redundant. Okay. Iris registration. So there are 48 landmarks used for matching the wave scan and the iris images. And so I think I need to go back to those pictures. So when the patient goes in to get their wave scan, what the machine is going to do, it's going to take pictures of little crypts in the iris to help get things aligned properly in surgery. That's what it's doing. Okay. I'm just going to go ahead. You don't need to know all the details. Yeah. So it's looking for reference points to get things lined up properly. And so in surgery, we're going to see little boxes like this. Let me just see if I can. Ugh. Okay. This is a lot of stuff here. All of these things our technician's going to do for us here. It's saying here, it's our responsibility to make sure everything is lined up, and our technicians as well. You're not coming back to surgery unless everything is lined up properly. I want the interop shots here. All right, hold on. I need to cut this talk down a little bit. Ugh. Okay, this is what I want here. In surgery, so you got the patient ready to go, and this is what it's going to look like before you press the foot pedal. You've got everything lined up. I'm going to have you before surgery at the slit lamp put marks at 3 o'clock and 9 o'clock on the patient on the white of the eye, just in case we have trouble getting iris registration, and we have to do things manually just to help line up. But anyway, once everything is all lined up and Seth says we've acquired iris registration, this is what the picture looks like right here. It's all lined up and ready to go. And then Seth's going to say we got 139 pulses, 7 seconds, and the depth, you'll see all of that in surgery. And then it's time for you to focus on the patient. You press the foot pedal, and then we go ahead and treat. He'll call out the pulses or the seconds so you know where you are. And so it'll go by very fast. Yep, ready, aim, fire. Okay. The system has to be calibrated. And so when we walk in and right before the patient gets in, Seth is going to be doing this. And so he's going to do like a -4 sphere. And then he's going to have me look at the ablation profile on a lensometer. So after every third treatment, he's going to be doing this. And so as soon as I walk in the room, he's going to have like a lensometer set up. It should be set to -4. Everything should line up and be in focus. And so he's going to be testing the laser to make sure everything is firing good. I can tell you from our results that the laser's working good. Hopefully Dr. Hagnagadar and I are going to go through our results of the custom or the eye design treatments and make sure that, we don't need to change our nomogram, or if we do need to change it, we know what to do. And this is what it'll look like. So I'll walk in the room and then he's doing his test treatment. Then I'm going to be looking at this lens under the lensometer. It should read -4. And we'll go from there. All right. So this is what he's doing here. So everything that goes on and in and around the laser room is the responsibility of the operating surgeon. Remember that, because that's what the judge is going to say in the courtroom. All right, big data. Everything comes down to big data. You do have to follow everything that you do and determine what you're doing. Is it statistically significantly good or bad? And then you have to make adjustments. And so remember that. Nomograms developed for other laser systems cannot be used with the STAR S4 system. So nomograms for conventional and eye design procedures are different. And let's talk about those nomograms. All right, we have already talked about these things here. Very rarely you're going to have to do this. Enlarging the optical zone is going to result in deeper ablations. Yeah, you're going to take away more tissue, takes more time. Enlarging the ablation zone is going to result in longer treatments. That is all self-explanatory. Okay. slide 22, when I talked about eye design treatment selection, number one, manifest refraction. We do manifest refractions in short rooms. We do our cycloplegic refractions in short exam rooms. And so, and then the refraction and optical infinity, more minus power is going to be needed to achieve the goal. And that's what the eye design takes in consideration. And so if you don't consider this, you're going to have uncorrected patients, meaning that if you go by your refraction in the exam room, your young patients especially, are going to be undercorrected, and they're going to be wondering, like, what the hell happened? I thought I was supposed to see 2015. And so that's all I'm trying to say. We're taking everything in consideration. We're not going to leave you hanging. You're going to have great outcomes. We've talked about the physician adjustment. All right. In order to develop an individualized nomogram, a careful retrospective analysis of your refractive result is required. I need to do this. I've been here 4 years now. I think I've used Custom View 2 years, and now the iDesign 2 years. It's time now to look at the patients we've treated and build a specific nomogram for KU. And so that's what I'm going to be working on this fall. So, all right. What this is trying to say, when is the refraction stable after surgery? Myopia, probably 3 months. At hyperopia, 3 to 6 months. Sometimes that's age dependent, and mixed astigmatism, 3 to 6 months. I'm just going to just say this. Most patients are very stable at 3 months. I think what they have at 3 months, they're going to keep for a long period of time. And so you need to have your discussion on enhancements and all of that at the 3-month visit. But I'm telling you right now, you're not going to have that discussion. Most patients are going to be on target because we're going to think about things ahead of time, and we're going to do the proper treatment. Many factors may influence individual nomograms. Temperature. So we document the temperature and humidity on every case so that we can go back and build nomograms. Patient age is important, what their refractive error is, whether you use a microkeratome, your elevation is important, and also your surgical technique. And so all of those, change one variable at a time. So if you find that something's not right, don't change multiple things, change one thing, and then do some cases, come back and look at it and see, was that significant? The percentage nomogram adjustment allows the surgeon to make a percentage adjustments to the entire wave scan defined ablation. Okay. The maximum amount of 10% change is allowed. That's your maximum. So, and the way you do this is that I'll have to go to the wave scan machine, and I'll have to put in this position adjustment, and then on everybody that we do testing on, it'll automatically put my KU position adjustment on. And so after you've done a number of cases, you'll build your own nomogram. You'll go back to the iDesign wave scan machine. You'll find this button here, and then you'll put your percent change, whether you want to add correction or lessen correction. Okay. Okay. Ooh. I said here, I personally don't understand how the calculated depth does not change, but this is a good thing. Okay. It says here, the percentage nomogram adjustment does not affect the calculated depth, the maximum ablation depth. I don't see how that can be true. I mean, if you're changing if you're adding or changing your nomogram 10%, like if you're increasing it or decreasing 10%, it seems to me it has to change ablation depth, but they say no, that it doesn't. So I'm not arguing with it anyway. The percentage nomogram adjustment is preferred for nomogram adjustment purposes because it adjusts the entire wavefront treatment, not just only the sphere. So maybe that's what's going on. So, all right. All right. Anyway, You don't have to know all of these things for right now. This is giving you some demonstrations of how that changes. I'm not going to go into that's too complicated. You need to know how to use the machine and understand why we do what we do. Okay. Again, so on the morning of surgery, you're going to receive an eye design map. You know, you're going to get an eye design treatment plan, and it's going to have the treatment at infinity based on what it just thinks we should do. It's going to have your manifest refraction in the exam room and your cycloplegic refraction in the exam room. And then you're going to have the ability to adjust that. And so you can change the sphere minus 0.75 to plus 2.75. It's going to be, so that's our call. We can't do anything to the a cylinder. We can only adjust the sphere. Okay. All right. So then we're going to load the eye design treatment on the machine. We're going to verify the correct treatment for the patient. We're going to verify the treatment parameters. We set the microscope magnification to 1.6. We adjust our ring and oblique illumination. We adjust the reticle illumination. You know, if we go ahead and we create our LASIK flap, then we go ahead and then we position the patient under the laser, and then we do the fluence check and all of that. We elevate the flap. We do we focus the laser onto the cornea. We engage the active tract, engage iris registration, and then we do our treatment. All right. So let's say the iris registration does not engage. We check the patient alignment. We confirm that the microscope magnification is 1.6. We focus on the anterior stromal surface and then we re-engage the iris registration. Attempt 2, if it doesn't work, we're going to decrease illumination, re-engage the iris registration. Attempt 3, we increase illumination and re-engage iris registration. And if you still can't get iris registration, we go ahead and proceed without it. You're still going to be fine. Make sure that the patient is lined up on those axis marks, and that's going to help make sure that you're on axis properly. And so that's what we do. So very rarely does this happen. Okay, but occasionally it does. I'd say 1 out of 100 cases. You'll press the foot switch, you deliver your treatment, replace the flap, and then you know, we make sure we take a look at the patient after surgery. Before they leave the exam suite, you got to make sure that that LASIK flap is in position and everything is fine. If there are any wrinkles, any debris, we bring them back to the laser suite, lift the flap, and my wife is laughing. She's listening because my sister-in-law, I had to go take her back and lift the LASIK flap up. She played in the sandbox with my kids. So, all right, if there's any one secret to effectiveness, it is concentration. Effective executives do first things first, and they do one thing at a time. And so, you know, when on laser vision correction day, we got to concentrate on what's going on right there and nothing else. That's what this is trying to tell us. And so I don't like doing lots of other things at one time because you can make errors easy here. Okay. It wants us to go over now the conventional ablation steps. So let's say we have a patient, they're out of the range for eye design 2.0 or something, and we have to do a conventional treatment. I've got one coming up. I've got a patient who had acanthamoeba. I did a DALC, and I can't get a wave scan reading on him. And so I've got to do a conventional treatment based on my manifest refraction in the exam room. And so, yeah, so sometimes it happens. And so I can do a treatment. I can tell you his refraction right now. He's like about a -5, +5 at something. And so basically what I'm going to do is I'm going to do a 6.5 millimeter treatment. It's basically going to end up being something like a -0.5 diopter, -5 at some axis. And it's all going to be within a 6.5 treatment zone inside his keratoplasty, and I'm hoping I'm going to knock out the bulk of his cylinder, and he's going to be a happy guy. And so it's easy. So don't fret if you have to do a conventional treatment, but we do have to follow the nomogram and all of that. And so with the conventional treatment, you can do a blend zone with the our scanning laser delivery, and it'll give you nice smooth ablations, and you can have great outcomes. It's just you don't have the topographically guided treatment. You don't have the wave scan guided treatment to get rid of other aberrations. So remember that the Excimer laser treats the minus cylinder axis of astigmatism. That's why I converted that refraction to minus cylinder. So make sure that you program the laser correctly. It's your job as the surgeon to do that. And so I'm going to, so when I give the preoperative sheet to Seth, it's going to be in plus cylinder. The laser is going to convert it over into minus cylinder because that's what the laser treats. The laser treats the minus cylinder axis. So make sure you're good at your Jackson, your was it Jackson cross cylinder things and all of that stuff, and making the conversions. It's very important you know that and understand that. Hyperopia, the ablation diameter goes from 5 millimeters to 9 millimeters. You're removing tissue in the periphery. Myopia, you're removing tissue in the center. And so that's what these are talking about here. All right. Treat the manifest refraction. I would do a 10% reduction in spherical equivalent if mitomycin C is used so that you don't do an overcorrection. That's just kind of my own nomogram. In general, at Iowa, we would use Dr. Sutphen's Navy data. Okay, so for patients less than 30 years of age, we would do a 10% reduction in spherical equivalent on all cases. For greater than 30 years of age, we'd use a 15% reduction in spherical equivalent. Again, this is what we used at Iowa. We had great outcomes on our patients that had conventional treatments. I looked at all of our cases from 1999 to like 2000, I think it was 2012 or something like that. And this includes our custom view with conventional. We had patients ranging from plus 5 to minus 14. And would you believe we had uncorrected vision 93% of those? You can do really good with conventional treatments, okay? You don't have to have the eye design, but I mean, if I had treatment on my eye, I want eye design, but you don't have to have it. Some patients, and what I tell patients is, if you're a candidate for a customized treatment, you're getting it because you're important to me. But if I can't do it, that doesn't mean that you can't have laser vision correction. I might not be able to give you the best procedure, but you can still do good. And so anyway, all right. I don't follow all of this. Just follow that Iowa nomogram, the Navy nomogram that we use, and you're going to do fine. Mixed astigmatism treatment. I don't do anything. The manifest and cycloplegic refractions need to be pretty close together. I usually go with the manifest on most of these, unless I know that there's some accommodation problem. And again, this is something special we'll have to discuss. Okay. These are just screens that you're going to fill in when we do the treatment. You won't be filling in these screens. Seth, the laser technician, is going to be filling it in. You'll be coming over his shoulder and looking and confirming everything before the treatment is done. So all of these screens need to be filled in ahead of time. I'm just going to motor on through here. You'll have to let your laser technician know what's your method of epithelial removal. Here I use, I do 2 types of removal of epithelium. We'll do the amoil scrubber, or we'll do laser scraper. We'd do the phototherapeutic laser to remove the epithelium, and then we'll do the Excimer laser to do the rest of the treatment. And so you're actually going to see that Thursday if you're with me. I'm going to do a PTK first to remove epithelium inside a graft, and then I'll do the treatment. So, all right. This is all kind of redundant here. So the steps in your conventional LASIK procedures, you're going to create the flap with LASIK. Position the patient under the laser. They'll do all the fluence checks. You're going to elevate the flap or remove the corneal epithelium, focus on the anterior surface, center the reticle over pupil, engage the active track system, depress the foot switch, deliver your treatment, replace the flap. We're going to go take a look in the exam room before they walk out the door, get their eye drops and everything in order. And that's what it's going to be. Okay. You must be the change you wish to see in the world. That's by Gandhi. And so my change, I want this laser vision correction to be just flawless. I'm hoping you all are going to be the nucleus so that 5 years from now, you're going to come, the resident who's on the service, they're going to have automatically have patients ready for them to do. The system is going to be in place and it's going to be no big deal. And we're going to be one of the best programs ever because we're doing this. And so, okay. All right. Looks like I hit here. I left enough time for questions. Questions, anybody? So we've been through the laser system and what to expect. We're gonna do the wet lab next Thursday, for the seniors. I'm going to coordinate another day when the laser is here, and we're going to do the rest of the residents. We're going to have donor eyes, and we're going to go through the wet lab so you can have a chance, so that whoever comes on the service and we've got cases, you've got a chance to do things. I don't need to do any more cases. You know, I've done a lot. It's time for you all to learn these, and so we can make KU one of the best programs where you do everything. So, questions?
I have a question, Dr. Goins. It's Megan here. First question is, like a lot of women in particular who are of the age of refractive surgery are on like oral contraceptive pills. And I know some people see that as like a relative contraindication. What are your thoughts about that?
Okay, question for everybody. Why would being on oral contraceptive, why would it be a relative contraindication? What does it do? You need to be able to answer that. This could be a board question. Does anybody know? You can speak up.
Just like changes in hormones causing refractive change, like thinning or thickening of the cornea.
I don't think that is the major issue. Sure, it does do that, but the big reason is a lot of women who take oral contraceptives, they get ocular surface disorder, dry eye. And so that's really the biggest reason. But you know, the ocular surface kind of needs that estrogen burst. I don't know what it is, the meibomian glands, the accessory lacrimal glands, they kind of need that little estrogen burst. And when it's like interfered with menopause or contraceptive or any other type of like steroid delivery, it alters things. And sometimes you get keratinization, you get dryness of the surface of the eye, and that's the big reason. And so I think you can medically microtune many patients and get them ready for surgery. So you want to do your Schirmer test. You want to look at the meibomian glands, and maybe they need medical microtuning. They might need a short course of either doxycycline or what's the antihypertensive they use for acne?
Spironolactone.
Spironolactone. It's very effective in treating meibomian gland dysfunction, and so or LipiFlow. Maybe you want to do that, and so hopefully we're going to have LipiFlow available to us. And so if there's a weak Schirmer test, you might want to put plugs in, or maybe we start Restasis early. There's studies to show that maybe Restasis, by enhancing the ocular surface, improves the outcomes and refractive stability after refractive surgery. So that's a very good question. You don't have to write these ladies off. No, we can do them. They might need a little love and a little bit of medical microtuning.
Great. Thank you. Another question.
So hold on one second.
The patients that you're doing.
Hold on one second. I'm on call here.
Okay.
There's somebody in the ER in Topeka with a metallic foreign body. I need to figure out, did it go through or is it just in the cornea? How can I help? Well, is there any hint that maybe it had something penetrate the eye? Did you get a vision on it? Or it's just too hard to do? You definitely see something there. Okay, all right, fair enough. Okay. All right, we have two options. I mean, come to the emergency room tonight, and or I can see. I'm in clinic tomorrow afternoon. I can see him tomorrow afternoon and remove it. Not a problem. Okay. If you can somehow, if you can maybe start some antibiotic drops just to make sure that, or an antibiotic ointment or something to make sure that he's got no infection, and then I can remove it tomorrow in clinic. 7400 State Line Road, Prairie Village, Kansas, KUI. Have him come about. I'll take him to the first station right at 1 o'clock. Perfect. Got it. That's fine. We got it covered either way. Sure. Yeah. Thank you. Sorry. Everybody there?
Yes.
No worries at all.
Okay. Was there another question?
Yeah, I had a question. It's Megan again.
Mhm.
So with that patient that you did LASIK, who had a PK, like what is the risk of like ripping off their graft with the suction from the femtosecond? Like, do you have to make any adjustments for that?
That's a good question. I can tell you a funny story. So I had your same exact fears. I did my first LASIK after keratoplasty. I'm trying to think. It was 2003. I just moved to Iowa, and I met Dr. Sutton, and so this lady came to me, and so I did like a deep lamellar endothelial keratoplasty on it. It was my very first one, 20/40 uncorrected. How about great beginner's luck? So then her other eye had a PK, and she was about -5. I mean, she was like -8 +5 or something like that, and she was just pretty miserable. And so I took her to Dr. Sutphin. I said, "Well, what would you do here?" And he said, "Well, I'd do LASIK." And I felt like you. I was like, "Well, what happens if things rupture or whatever like that?" And so back then we were using microkeratome, and so um, um, with the microteratome, it builds the pressure up to 60. And so, yes, you do run the risk of everything opening up, but I did it. And so you do, and back then you would do it in stages. You would cut the LASIK flap, and then you put the flap back down, because just cutting the flap gets rid of some cylinder. And then you refract the patient at 1 month, and then you treat whatever's left over. And so I did that for her, and I made her, she was pretty much balanced. And so she was like the happiest lady ever. But the femtosecond laser makes it much more safe. The pressure does build up in the eye with the femtosecond laser, but with the way the laser works, there's no steel blade coming across the wound. You're putting you're putting all of the flap inside the cornea, and you never want to do it in an eye that doesn't have really good wound healing. And so if the wound healing is suspect, you're going to do PRK. In fact, I almost always do PRK now. I don't know what made me do LASIK and why I decided to do. I don't know why I did LASIK then instead of just doing a PRK. So you make a very valid point. Maybe I was just younger then and kind of just more daring or whatever. But it worked out really well. And so yes, there is a risk, and but you just have to make sure the wound healing is good. You just have to have faith that in your technique and abilities. And I don't know, I lucked out.
Nice.
I have one
Last
lecture.
question.
I have one
When,
lecture to give to
so
you
like-
all. Yeah, I have one lecture to give to you all. I have a whole lecture on a collection of cases that I did femtosecond laser LASIK on. And when you see it, you're going to be like, wow, sign me up for that. I want to start doing that, because the outcomes are really, really good. But go ahead.
On that note, so if all the PGY4s get certified, can we be doing LASIK during our last year here on patients?
Yes, yes. You got to be certified on the VisX first, and then there's no way for you to get certified. I don't think it's physically possible for you to get certified on the femtosecond laser, but that doesn't mean that you can't do LASIK. And so I'm going to be with you. I mean, you're going to have me there, and you will have me there, and I'm going to guide you through it. You know, we got to make sure we choose the appropriate patient. They have to have good anatomy, and they have to have the right expectations and all of that kind of stuff. But there's no reason why you can't do it. We're doing the same thing we did at Iowa, and so if somehow we get it set up so that we've got streams of patients coming in, you know, for resident refractive surgery, then yeah, if you get 5 patients together and you're ready to do them, we can get you certified on the femtosecond.
Okay. Like if we have friends or family who have been interested in this for a little while, could we?
Yes.
Okay,
Right.
great, perfect. All right, that's it.
We just this is our problem because we don't own the laser. The facility fee cuts us back. See, in Iowa, they own the laser, and they made a deal with like the president of the hospital, so they're able to do like both eyes for $750.
Wow.
That's what I'm saying. Wow. Whereas here, the site path, they want $1,400 per eye as their facility fee. So there's no way we're going to get it less than 1,400. So Abby's telling me that maybe we can do it. We can give the patients a third off.
Okay,
I mean, that's better than nothing, but I was hoping we could do something like a 2-for-1.
yeah, that'd be great.
I mean, if we could do a
Half off.
2-for-1, I think you all could get a lot of volume coming in.
Yeah, I think so too. I've had a lot of people ask, so great.
Well, I'm working on it.
All right. Thank you.
So one thing I want to do with with y'all's permission, I know this is late, but maybe find some extra time on the lecture schedule. I want to give another lecture on phototherapeutic laser too. So everybody can be certified for that. I need like another 45 minutes for that. Maybe I can do that on a lecture morning on to get everybody certified on. You'll be certified to do the Excimer laser, PRK LASIK, and then you'll be certified to do phototherapeutic laser. It's a separate lecture. So
Yeah, we can switch one of your already scheduled morning lectures to that. Whichever one works best for you. I can forward that email back to you, but yeah, we can certainly do that.
okay. All right. You all have been very good. Thank you on short notice for doing this. This helps out a lot, and complete everything online, and then seniors, hopefully I can see you maybe 1:30 something between 1:30 and 4. Hopefully we can go through the steps using both lasers so you feel comfortable. And I'll be there. The trainer from Abbott will be there, and you know, we're just going to go through things and get things done. And I'll have donor eyes. I'll have artificial anterior chambers. You'll have all the instruments there so that you can practice your LASIK flap lifts and then your ablations and all of that stuff. So.
Thank you, Dr. Goins.
All right. Who's on call tonight?
Me, Sarah. Thank you.
So,
Yeah.
all right. So there might be a person with a piece of metal in their cornea from Topeka coming. I don't know. I tried to save you that and get them to come to see me at 1 o'clock tomorrow in clinic. So.
Well, thank you so much for your support. Really appreciate that. We'll be ready if it comes though.
Okay. Fair enough. All
It
right.
won't be coming to Opthos service though, right? It's just coming to the ED.
Come to the ED.
Okay, cool. Sounds good.
All right. Thanks, everybody.
Thank you for the lecture. Bye.
Yeah, thank you so much.
Thank you.
Thanks, Dr. Goins.